So if y'all have logged into Socrative, you can do it quickly. Socrative.com, Scrubs DES. If you want to just do it interactively, it's got the explanations there. We'll go through. I post a lot of additional stuff on the drive on Scrubs DES, like tables and graphs and stuff, along with all these reviews, and the question sets are done separately. So if you just want to do the questions or you want to go through the reviews, everything's there for all three of my MSK reviews. Obviously, y'all know by now, grades is super important. Make sure you do the questions. And let's get started with the pelvis. I have 10 people logged into Socrative now. Okay, cool. Yeah, I'll put the thing up again. So like I said, these are all very high yield. And I've got some tricks to learn some of them. First time watching Matrix. That's something. There you go. Yeah, that's the truth, isn't it? All right, so let's get going. Looks like, yeah, I mean, based on how y'all do on these questions, I could see the results. We'll go through it. So it's a lot of words just asking you where the internal spermatic fascial layer comes from, right? So if you look at it here, the coverings that come from the abdomen kind of make the scrotum and the layers here. The trick I always use is ice tie. So if you like lay them right ice over tie, the I goes to T, obviously. But this is how I remembered it, okay? So I'd imagine you would have a question on it. That's a good mnemonic to remember what
You'll
comes
probably
from.
have multiple on this.
Yeah, maybe so. Yeah, they like that. All right. You will have multiple hernia questions, so we're going to make sure we have this lined up. All right, y'all did well with this one too. Basically, from the stem here, it comes down. Is it direct or indirect? And the key here is the deep inguinal ring. So that's going to be indirect. So the first thing you want to do when you're thinking about these is where is it in location to the inferior epigastric vessels? Medial to it will be direct. Lateral to it will be indirect. I kind of think as indirect as kind of to the side, so it has to take an indirect pathway to get into to the hernia, the location of the hernia, meaning that it has to go through both the deep and superficial rings. Whereas direct is medial to the inferior epigastric vessels, so it kind of goes straight through. So when you're talking about medial or direct inguinal hernias, you're thinking of a strain, whereas these indirect inguinal hernias typically are congenital. Okay, make sure you have that straight in your head. Oh, I might be covering this up, sorry. Oh. All right, very well done. So, yeah, y'all know this. And the point is, patient comes in, signs of appendicitis, right? It starts with this visceral pain that kind of goes periumbilical, and then it gets more intense where it goes to the right lower quadrant, sort of aggravating those peritoneal fibers, those somatic fibers that are right there. So what are we going to do? We want to take the appendix out, right? So the appendix location that we use is McBurney's point. So 2/3 the distance from the umbilicus to the anterior superior iliac spine. So if you take your thumb and your index finger and you put it from your umbilicus to the anterior inferior iliac spine, you kind of make that line. So this is the point where the appendix is, but y'all did good with that one. I did add this in here. I don't have a question on it, but there is an important landmark, the arcuate line. So anything above the arcuate line, you're going to see half of the internal obliques, and the transversalis fascia is going to go behind the rectus abdominis muscle. Whereas below the arcuate line, everything's going to go in front. So they could ask you a question. They could describe this and say, what is the landmark here that differentiates this? And you want to know it's the arcuate line. All right, try this one.
Make sure that everyone's microphones are muted. I'm just muted a couple people, but I can only see a few on my screen. So make sure that you do that.
Okie dokie, y'all did good on this one too. So we're talking about the cremasteric reflex, right? So we're basically asking, what is the motor limb to that, right? There's an afferent and an efferent branch. So when we're talking about the motor aspect of this reflex, we're talking about the genital branch of the genital femoral nerve. So this is important, these landmarks, you know, that the iliohypogastric runs above the ilioinguinal, and they kind of wrap around the inguinal canal. And you could see here, so the afferent or sensory pathway is going to be ilioinguinal, whereas the motor pathway, as I said, is the genital branch of the genital femoral. All right. A lot of people were concerned with what do I need to know in regards to the blood supply? So as I've been saying, you definitely want to know the clinical applications, but what they like to test on are the collateral circulations, or these anastomoses. So that's what I tried to include here. If you have a blockage in one area, how do you get blood flow to that area, to the downstream area? All right, let's take a look. So huge problem here if you have a blockage of the inferior vena cava, right? That's going to bring all the blood up from the lower limb. So you need to have an anastomosis there. So what you use in this situation would be the ascending lumbar. So this is a little tricky. Remember that azygous and hemiazygous, what side they run on, and then versus the accessory hemiazygous. Okay, you want to keep them straight, and these are going to be backflow areas that are going to bring the venous blood back into the atrium.
I did have a question about that last slide.
Yeah.
So would it be like the azygous vein if we were looking for the blood flow back into the like back up
Yeah, right. So the azygous vein is going to be the primary vein, and then the accessory hemizygous vein is going to feed into it and bring it back up. Yeah. You just want to remember that the azygous vein runs on the right side. It's not the best image, but yeah, the azygous vein's down here. You can see. All right, let's take a look at this. So during pregnancy, relaxin is released, and it kind of relaxes the pelvic girdle and allows the baby's head to fit through into the vaginal canal. So we're talking. So one of these is not actually going to expand, and that's going to be the true conjugate diameter. That's basically your anterior posterior axis, right? So here to here. So this isn't going to expand, whereas these diagonals will kind of be able to expand a little bit. So it's a good point. I would know these just to make sure you know what correlates with what. This is super high yield. I remember this one.
Yeah.
And before, there was one that changes the most. Is that the which one is that? Is that the?
That's a good question. I don't know.
I remember seeing it somewhere, but I actually just don't remember right now. But I believe it's the red one. It's the conjugal diagonal.
Conjugate diagonal? Maybe.
Yeah.
Sorry, I don't know.
What was the question?
Which distance changes the most?
I think it's the inner spinous.
Inner spinous? Okay. That would make sense because that's your smallest segment. So to fit the baby's head in, that would make sense. Yeah, thank you. It is the narrowest, yeah. All right, looks like everybody knows this one, right? So we're talking about that pubococcygeus muscle. The one thing I would say is be careful because there is a little ring here, the puborectalis. They could use those interchangeably. I wouldn't imagine they put puborectalis and pubococcygeus in the same, answer choices. But yeah, puborectalis is kind of this inner ring here. But you're worried about rectal incontinence with injury to this pubococcygeus. Try this one. All right, very good. Y'all got these. Yeah, so remember that when you check this Trendelenburg sign, you might think you would use the gluteus maximus, but it's actually the medius and minimus, right? So if you look here, you can see this paralyzed aspect is actually going to be the higher, and it seems a little counterintuitive, but that's how it works. The paralyzed side will be up. So when lifting the left leg off the ground, that's where you see this waddling gait appearance. Good. All right, let's go into some lower limb stuff. I'm sure y'all recognized that the lower limb is very similar to the upper limb, right? So whereas the upper limb, you have the radial, median, and ulnar nerve, you have the similar architecture in the leg, right? The wrist correlates to the ankle. So we're going to use a lot of those concepts going forward to kind of, understand it more than memorize it. All right, let's take a look. So when we're thinking of avascular necrosis, right, we're thinking about that injury to the femoral head or a hip, or not a hip fracture, but a superior aspect of the femur injury. When you think about avascular necrosis and compromised blood supply, you're thinking about intracapsular, right? So the blood supply is going to be the medial circumflex. That's what's going to be compromised if you have this sort of injury. So quickly, let's look at this. This is the normal architecture, right? So this Shenton's line should be straight across, right? That means you have that means that everything is okay. What you see is if you see this fracture, right, this shortening distance here, you can see the fracture. Look at Shenton's line, how it's compromised, right? It's not straight. So here we're talking about this intracapsular, right? And you can see it here, this intracapsular injury or injury to the femoral head, to the neck of the femur, gives compromised blood flow to the head of the femur. So obviously you don't want an extracapsular, but if a patient comes in, you prefer to have extracapsular to intracapsular just because of the blood flow and because you're mainly worried about this avascular necrosis. These branches that come off of the medial circumflex are going to be the retinacular arteries, and that's what's going to feed the head of the femur. I know it's tricky, the ACL and PCL. By the time we're done with this, you will be able to recognize them on an MRI, I promise. So try this one. This one's pretty straightforward. All right, so this one's pretty easy. Talking about the ACL, we're worried about this anterior drawer test, right? So when you think about this, the drawer is the tibia. So you basically put your thumbs on the patella and you kind of press behind the tibia, and the tibia comes out anteriorly towards you. So that's what we're going to worried about with the ACL. So it runs in front, obviously, of the PCL. We're worried about the anterior drawer test. That's how we're going to test it. PCL will be posterior drawer. Again, you can see this here. If I'm going fast, this will all be posted, so don't stress. I just want to get to some of the more difficult parts. So this really helped me out a lot. The red's going to correlate to the ACL, and the blue's going to correlate to the PCL. So if you start at the femur and you go anteriorly, that's going to be the ACL. If you start at the femur and go posteriorly, that'll be the PCL. And that's going to help when you look at these. So if we look at this and we're trying to determine, okay, this is an MRI. If we're trying to determine, is it ACL or PCL? Well, let's start with the femur. You can see the ligament is going posterior to anterior. So that makes sense. That should be the anterior cruciate ligament. So it like if you pulled this leg forward, I would pull the tibia forward, that would be the anterior drawer test. So you could see how this ligament is holding, the ACL is holding the tibia from going anteriorly. So if it's compromised, that anterior drawer test will be positive. Okay, let's take a look at the PCL. Now, I imagine on the test, they won't put the ACL and PCL. You won't see them both. It'll be very clear like this, right? So first, let's start with the femur and go to the tibia. You can see here, right? It starts here and it goes posteriorly, right? So it's preventing the tibia from being displaced posteriorly, or the posterior drawer test. So that's going to be the PCL. Again, you can look at the diagram here and that'll help you out. All right, let's try this one. Obviously, y'all have mastered the Gray's questions. These are pretty easy for you guys. The reason I put these on here is because they're very high yield concepts. So if y'all could get these right, y'all should feel confident going into the exam, at least with the anatomy component to it. All right, so this is classically how they're going to ask this question. Oftentimes they'll use some sort of sports injury, here football. The player gets hit posterior laterally. Does anybody know what this is called, this triad?
Unhappy triad.
Very unhappy, right? So here the ACL is what's going to be injured. Typically, if you have an ACL injury, you could, you could look to see if there's an MCL and medial meniscus or lateral meniscus. But oftentimes, unfortunately, they happen in this triad formation, right? So this is kind of the question that we posed, right? The player got hit in the side laterally. When you hit, so find the fibula, that's the lateral side. If you hit the leg here, you're going to tear the medial side, right? So just remember, of course, the ACL is going to be what you injure, not the PCL. Other than that, the medial is kind of obvious. It's still debated out there which one happens, medial or lateral, but it could be one of the two. So just a quick point, housemaid's knee versus clergyman's knee. If you kind of think about it, if a housemaid is kind of leaning over, cleaning the floor, she's going to be at more of this superior aspect of the knee, the prepatellar bursa, whereas a clergyman who's praying, who's on his knees, will be in more of the distal aspect of the leg, right? So just keep those in mind. In regards to a Baker cyst, remember that happens posteriorly here. All right, a couple of things that weren't exactly straightforward in the lectures. There's a valgus deformity and there's a varus deformity. So valgus means the distal fragment from the joint of interest is displaced laterally. Varus means this distal fragment is displaced medially. So in regards to the femur, okay, excuse me, you have a valga deformity if this angle is increased, right? So this would be the distal portion, the femur right here, right? So if it's spread out or laterally, you're thinking valga versus if it's spread medially or towards the medial aspect of the body, it'll be vara. Genu similarly, so we're worried about the knee. So what's the immediate distal component? That's going to be the tibia, right? So if you have knock knees, the tibia is going to be displaced laterally. That'll be valgum. Bow legs, the distal fragment is medial, so that's varum. This is from lecture. Typically, when you have this, if you look at the toe here, it's displaced laterally. So that's going to be a valgus rotation. Often it's accompanied with a bunion. The varus rotation, the toe is going to be displaced medially. Okay, so just keep those in mind. Try this one. This is another one of those blood supply questions. How can you ask a blood supply question in a clinical aspect? Well, you block one of the arteries off and ask about the anastomosis or collaterals. All right, so y'all are good with this. Let's go forward. Popliteal artery, very important, going to give blood supply to the lower limb, past the knee. So here, where the anastomosis or collaterals is going to come from the lateral femoral circumflex. Remember, the medial femoral circumflex is compromised when you have that intracapsular femoral head injury. The lateral femoral circumflex is going to give blood supply in the event that popliteal artery is compromised to the leg and foot, and you could see that here. Find the fibula. You're on the lateral side, so this drainage would come here if the popliteal artery was compromised. Good, y'all are doing well. All right, so we've got a split of votes here, which is an important component to this because they can ask you these sort of questions two different ways. They could say you have an injured nerve. What's the deficiency, the motor or muscle deficiency? Or they can ask you, you have an injured nerve. How does the patient present? What is working? So in this situation, we're saying that tibial nerves injuries. So how would the patient present? Okay, so the tibial nerve, the posterior aspect of the leg, is going to help you push on the gas pedal, right? Stand up on your tippy toes. It also provides a component to inversion of the foot. So if you cancel that out and the tibial nerve is out of commission, the foot's going to be dorsiflex, the toes are to the air, and it'll be everted. And you can look here. I think this helped me out a lot. So where the posterior compartment is out, right? So again, the inversion and the plantar flexion is out. So you're left with activation of the anterior and lateral compartment. So the deep fibular and the lateral compartment, the superficial fibular nerve, are going to be working. So that's how the patient would present. All right. So just be careful with that. How does they present versus what's injured? And the same thing could go with the hand too, right? Remember, they could ask you, or the wrist or the hand or the upper limb, if you have a radial nerve injury or whatnot, how's the patient going to present, or what can they not do if you ask them to make a fist or whatnot? All right, this one's a little tricky. You have to read into it, okay? Now, there's a split here. Common fibular, which gives branches to the deep fibular and superficial fibular. So before we do this, right, we're talking about foot drop. What if you have a wrist drop? What nerve is injured?
The radial nerve.
Yeah, wrist drop, right? So you can't extend the wrist. Similarly, the ankle acts as the same, similar to the wrist. So we're saying if we're trying to decide common fibular versus deep fibular, because foot drop, well, you can't dorsiflex, right? But look what they say. You have sensory loss over the dorsum of the left foot and the lateral leg. So you have to include both the superficial fibular and the deep fibular into the injury. So where do they, if you trace them back up, they come together at the common fibular, right around the point where on the lateral aspect, the common fibula kind of wraps around the fibula at the most superior end of it. All right. Let's try this one. All right. So this symptom or the syndrome should seem similar to carpal tunnel syndrome, right? We're talking, instead of carpal tunnel, we're talking about the tarsal tunnel. But similarly, there's that flexor retinaculum, right? Remember, carpal tunnel, if that flexor retinaculum doesn't really expand, it's tight. It's kind of like a wristband, right? So if you overuse the tendons in the carpal tunnel, it's going to impinge on the median nerve. So you'll distally on the hand, you'll get a median nerve injury or median nerve symptoms. This is very similar. This tarsal tunnel has a flexor retinaculum, and it's on the medial side by the malleolus, the medial malleolus. So basically, it's a lot of words just asking you what is the most anterior structure there, right? So a good way, so it's tibialis posterior. Best way to remember that, this little mnemonic: Tom, Dick, and very, very nervous Harry. Okay, so let's talk about it, right? So if you orient yourself, here's the big toe right here. So we're talking about the medial tunnel. This is that flexor retinaculum, right? So these nerves and these tendons are going to kind of coming together and go through there. So let's look at it here. This is a better image for me, at least. So we're looking at the medial malleolus here, right? That's the big toe. And these tendons kind of fall in line, right? So first one being tibialis posterior, second flexor digitorum longus, then you have the artery, vein, nerve, and then flexor hallucis longus. So they just like asking this. If you know the mnemonic, piece of cake. We did cover previously, all of the herniations. And so sometimes it's clinically relevant. If they give you a herniation, they could ask another like third or fourth order question and say, not only do you need to know the disc, but what are the downstream effects of it, right? So if you know the sensory innervation to these lumbar nerves, then you should be okay. Compartment syndrome is really important clinically. It's a medical emergency, right? So when you have some sort of drastic injury and you get swelling of the muscle, they'll give you these symptoms, right? These 6 Ps, and the patient will come in like this, just in an emergency. And so what ends up happening is there's so much pressure in the muscle, it exceeds your blood pressure. Therefore, arterial blood won't pass through. So you get necrosis of the muscle and everything that's underneath the fascia. So what they do surgically, they actually cut the fascia. You can see this white area because it doesn't expand. It's similar to the retinaculum. It doesn't expand. So you have to cut it to allow expansion of the muscles and allow the swelling to eventually go down. But obviously you need blood flow. All right, bones of the foot, need to know these. But let's look at some of the more clinically relevant aspects of it. The deltoid or medial ligaments are going to be on the inner surface, and then the lateral ligaments will be on the outside. Try this one. All right, 100%. Y'all did well. Okay, so when we talk about this inversion injury, the foot turns inward, right? So you're worried about stretching of the ligaments on the lateral side. So calcaneofibular is injured, but it's important to know it's not listed here. But the most commonly torn one or injured is the anterior talofibular. Make sure you know that if there's going to be an injury, anterior talofibular goes first, then calcaneofibular. So another good, for some reason, I remember a question about this. It may have been from Gray's on the test or something. The calcaneofibular is the lowest ligament, the most distal ligament there. So obviously you can tell what bones they come from because it's in the name. But for some reason, I remember a question asking which one was the most distal. Muscles of the foot, something you just need to sit down and memorize. I don't know, Lindsey. I didn't think it was too terribly high yield. The muscles.
No, the smaller muscles in the foot are not as high yield as the hand, because in the hand you have a lot more, with respect to what we're doing, you have a lot more pathology that's associated with the foot. The biggest high yield stuff are the sensory boundaries, because like the hand, it's very defined where those sensory boundaries end and where they are, and they can ask you the lateral or the first interweb space and expect you to know, because the superficial fibular nerve is going to be most of the dorsum of the foot except for the lateral side in that first interweb space. So you have to know that those two places on the dorsum of the foot, those aren't going to be the superficial fibular nerve. And so with respect to the foot, that's the most high yield. But the this stuff, not so much. It's the inversion, eversion injuries, the arches, because you can have an arch collapse. That's big too. But the little muscles in the foot wasn't very high yield at all.
What I did include, these lath muscles, or that was included in your lecture. Those are innervated by the medial plantar nerve. You can use the same mnemonic for the dab and pad as you did for the hand. Dab, dorsal interossei abduct, palmar interossei adduct, right? Varicose veins, they like this. As you get older, these veins are kind of compromised. They kind of fail on you. So what happens is these valves, right? These valves in these veins. And when these valves are compromised, you get increased flow to the superficial veins, which are smaller and more fragile. So what you see is you can see the veins in older people. They kind of get swollen, these superficial veins, but it's basically because you get these valves that are compromised. Okay, dermatomes of the lower limb, really important. Some of the more important ones, the L1 is going to be the inguinal canal. L4, remember, drop on all fours. That's your knee. S1 is going to be your Achilles reflex. Okay, this is good. I pulled this from first aid. Just good to know these in general. T4 is at the nipple line. T10 is umbilicus. L1, like I said, umbilical. L4 is at the knees. S2, 3, and 4, keep the penis off the floor. Haha. I didn't write it. First aid did, but you won't forget it. Great. So some of the reflexes. Remember that biceps reflex, when you pick up C5 and 6, you pick up sticks, right? So you use your biceps. C7 and C8, you lay them straight. So your triceps reflex. So you want to know those. As we said, with the S2, 3, and 4, that's the anal wink reflex. And think of L1, L2 with that cremasteric reflex as well. So these are good to know. Just commit those to memory. All right. And as Lindsey was saying with this first weight base, they love this question. She gave it away.
Yes.
But they love this.
I didn't say what nerve it was, though.
You didn't, right? Okay.
Didn't. I almost did, but I didn't.
You almost did. All right, cool. So y'all are killing it, right? So remember, if you see a situation where they're talking about this first web space, you're thinking deep fibular, the sensory innervation to it, right? You see this little yellow area, that's all innervated by the deep fibular nerve. As Lindsey was saying, the sensory innervation to the foot is super important. Remember, the sural nerve will run laterally, saphenous nerve will run, the sensory innervation will run medially. Again, here's the foot. You could see this deep fibular nerve, this yellow area. So it'll tell you somebody, like the question was, somebody had a knife that stuck right there. That's deep fibular.
Stuck on a nail, something like that. Yeah.
Yeah.
Or like drop
So,
something. Yeah.
yeah, for sure. So I know limb development was kind of thrown at you. We're going to go through a little housekeeping stuff, and then we're going to hit the clinical stuff, and then we'll go from there. So somites, remember there's three components: sclerotome, myotome, dermatome. Sclerotome is going to be your vertebrae, myotome, M for muscle, dermatome, obviously going to be your skin. I would put a star on this slide.
Yes.
Remember, specifically Sonic Hedgehog. If you remember the game, the Sonic Hedgehog had his mohawk. That's how I remember anterior, posterior. But correlate that with the ZPA, or the zone of polarizing activity, whereas that apical ectodermal ridge from fibroblast growth factors is proximal distal, and then the dorsal ventral aspect. Just commit this to memory and you'll be good. As for the weeks, I think if anything, you want to know that week 4 is that start of the limb buds appearing. But you can just make note of this, just kind of how they go. But if anything, I would definitely know that week 4 is the first part of the bud development. I did cover this on my first review, but it's just kind of, don't forget, remember when we're talking about this endochondral ossification, you're laying down cartilage and it's going toward the diaphysis, and then you're going to form bone. Remember those histology slides? If y'all haven't looked at them in a while, I would go back and look at them, those different zones, the stack of coins, that sort of thing. Just make sure you know that. All right. I just have 3 more questions. All right, looks like y'all are pretty good with this. So here we're talking about incomplete apoptosis. What is this called clinically?
Polydactyly.
This one's syndactyly. Yeah, exactly, right? So polydactyly is going to be extra digits. Syndactyly is going to be fusion of digits. So what actually happens is normal development, you're going to have like webbing of the fingers, or they're going to be joined. And normal development, you're going to have apoptosis of the area in between your fingers. So that's going to be normal, and it's going to form the digits, or the digital rays. So if that doesn't work properly, you can get syndactyly here. Remember, there's cutaneous versus osseous. Obviously, osseous is going to be the fusion of the bones, whereas cutaneous will be more of a webbing formation. Polydactyly, you're going to get increased a number of digits. And make sure you know this is disruption of the anterior posterior pattern. So remember, Sonic Hedgehog, he's got his mohawk, anterior posterior. So if you have a disruption of Sonic Hedgehog gene, you can end up with polydactyly. It's also as a dominant trait.
Can I ask a question real quick? Didn't the question say there were 14 digits?
Okay. Oh, good point. 14 phalanges. How many should you have?
Oh, so you're saying 20, not 10. I was thinking just one body part.
Yeah, right. No, because they're combined, right? So you had to count them both. Yeah, so this is an osseous formation. Yeah, I see. Yeah, I see what you're saying. But yeah, they're talking about when you separate them. Yeah.
I had a question about so when is it that the digital rays don't develop? Like I thought that was syndactyly as well, but I can see
Where I think I have a slide coming up where or maybe not the digital rays, but the limbs don't develop. I'm not exactly sure at what point in if they don't actually
because I
develop.
thought from Gray's like there was one question or there were a couple that was like for syndactyly it was like digital rays or something. I'll look it up and then I'll put it in the chat.
Yeah, please do. Yeah.
They're more focused on what doesn't happen.
Right.
So in this one, it's
exactly.
the failure of webs to degenerate. That's very commonly how they would ask that question.
Yeah, I agree. Like opposed to what's the normal
Lindsey,
formation.
Can you repeat that real quick?
So in this slide, it says in the cutaneous syndactyly, it says failure of webs to degenerate between 2 or more digits. And then the bottom it says failure development of notches between the digital rays. That is probably what you're going to see as an answer choice on the exam. And you're going to have to know based off of the failure or incomplete fusion or, I mean, there's so many that can happen. That's what they're probably going to test you over. They're going to give you the presentation of the patient. They're not going to diagnose the patient. They're going to expect you to know what it is. And then they're going to say, okay, how did this come about? And that's what they're going to ask you. Or they could flip it and they could say there was a failure of development of notches between the digital rays, and they could ask you to diagnose the patient.
So for the question we just did, because it said there was 14 phalanges, that indicates that there was a fusion of the bones, correct?
Correct.
So then we know that this one is osteosyndactyly. So,
right, I see it. Yeah, exactly.
So then, like they could have also written failure of development of notches between the digital rays.
It would have been the same answer. Yeah, for sure. Yeah.
Is that what the point you're trying to get across, Lindsey?
Yes.
Okay, cool. Thank you so much.
All right, let's see where we're. Okay, clubfoot. Make sure you also know that this word here, Pelvis equinovarus. That's my best guess at it. It also means clubfoot. Come on, Lindsey? Did I butcher it?
I do this all the time in small groups, so I can't laugh at you, and I give up every single time. I would say Pelvis equinovarus.
Oh, okay. All right. Yeah. Anyway, for some reason, I remember this coming up and being like, "What was that?" You know, Pelvis. Yeah. Anyway, that would be clubfoot. All right. Let's try this one. So the question you had asked, I know you were speaking about digits specifically. This is more of a complete limb failure to develop.
For the one that was digits, it's ectrodactyly. That's when it's failure of the digital rays to develop.
It's called what?
Ectrodactyly. I put it in the chat.
Okay. All right. Great. Thank you. I appreciate it. All right. So y'all are good with this. So one is shorter than the other. So when you talk about maromelia versus amelia, amelia is going to be complete absence. Maromelia is going to be a failure, shortening or failure of complete development. And again, Pelvis equinovarus, it sounds like a Harry Potter thing. I don't know. That's going to be clubfoot, right? So keep that in mind. Here you could see amelia, failure of complete absence. Maromelia is going to be like partially. So if it makes sense though, because amelia, if at the fourth week you're going to be starting to make limb buds, if you don't make those limb buds, you'll have a problem there. Where maromelia, you kind of started and then there was the problem. Again, it's multifactorial. There's a lot of components that go into that. Here you can see, I don't know if it's politically correct to still call it lobster claw formation, but if you have a failure of development, I guess, this is what you must have put, ectrodactyly. I couldn't hear you very well, but yeah, so this is failure of these digital rays to develop. So failure of development, you can get this sort of cleft hand or cleft foot appearance. Thank you for posting that. This is important. So even if the child is developing normally, sometimes it just happens that you get this fibrous band, this amniotic band that could cut off blood supply to the arm or to a digit, and you could end up with like a pathological amputation. This ring constriction can cause it. So keep that in mind. Don't look over this. For me, these seem like if I saw a question with these symptoms, I'd be like, I have no idea. These kind of are all over the place, right? But if you kind of commit them to memory, you can remember that this Bactrial syndrome has this compilation. And keep in mind that in the question, they can only give you they could just give you 3, and it still is classic for this Bactrial. Vertebral, anal, cardiac defects. I don't know if y'all talk about tetralogy or Fallot. That's what's common. TEF. And then you could have kidney or limb problems. All right, quickly, this is the last question I have. I expect y'all to do well on this one. I just wanted to make sure because this is super high yield. You'll have a few questions on it. All right, very good. So right, L4, L5, even though the L4 nerve will exit, it's spared because it exits above the disc, right? So the L5 is going to be compromised. I'll put this from my previous review. Just remember the cervicals, the lower one's going to come back out. Remember you have that C8 nerve too, so that's going to bump the thoracics down 1. So between T7 and T8, the T7 nerve is going to come out. For L4 and L5, even though the L4 nerve exits below, it'll exit above the disc, right? So the L5 nerve is compressed. This is, again, you can see that here. This L4 nerve is spared because the disc is below it. So you compress the L5. If you're stressed on the test, just remember this: nerve compressed cervical will be lower, as in C3, between C2 and C3. Thoracic will be the upper one. And at least for compression, for lumbar will be the lower one. This is my Facebook page. If y'all are not a member, all my stuff's posted here, the reviews. Also get on the Scrubs DES Google Drive. You could snap a picture of it here. I put all these question sets from all of MSK that I've done are there along with the review. So you can actually go in and just do the quizzes. You don't have to go through the entire review if you don't want to. Also, I put a bunch of additional resources that I found helpful last term, and you can get access to these reviews too. If you have any questions, put them in the chat, and I will hand you over to Lindsey. You could go ahead and share your screen if you want, Lindsey. Uh-oh, is she there? Hello? Are you there?
Oh, I got muted. I'm sorry.
Oh, no worries. Oh, you
I don't
okay?
know how that happened.
Okay.
Sorry, guys.
Go ahead. You can share your screen, Lindsey.
Yeah, hold on. 2 seconds. I'm cleaning this up because I don't want you guys to have to log on to another question system. So instead of you guys interacting over a poll, we're just going to run through some of these things. So I have some anatomy concepts, and I also have some muscle phys stuff for you guys. So some of it is going to be a repeat of concepts that Brady showed you, which means it's high yield if I on my own picked it out as well. So can you guys see my screen? Week 10 questions.
Yeah, your screen. Yeah, we could see that.
Cool. So you guys can just put it in the chat, your answers, and we can run through some stuff. Yes, I will post these slides. It's like, can I post a Oh, I just have to do it to one. Oh, is this? Oh, I can post an actual thing in there. That's really cool. Okay, I will do that.
We'll make a note. We'll go through the hernias again after. I'll make myself a note.
Okay, I just put the. I think I just. Okay, now it should be there. This PowerPoint that I'm doing right now. So we have one guess for fibula. Okay, so that is correct. It is the fibula. So you need to go through all of the joints and you need to know which bones are and are not associated with each joint, because even though there's a bone that's closely associated, it may not actually be involved in the articulation at the actual joint. So that is something that they can ask you for every single joint, the elbow, the wrist, everything, because when it comes to pathology, that can be really heavily associated. So you really need to go through these joints and know what is and what is involved in the actual joint, not just there, not just associated, but the ligaments, the bones, everything that's involved in the actual joint, because that can give you a couple points on the test. So just put in the chat what you think it is. Okay, someone has a vote for anterior. Anterior, yeah. So this is the concept that Brady hit on, is the compartments. And I personally think if you're having difficulty understanding the muscles, understanding the actions and innervation, organize it by compartment, because each compartment is going to have relatively the same actions, and they're going to have the same innervation, and they're going to be very closely associated with their blood supply. So if you're having trouble going through the muscles and you are still trying to understand all the mechanisms, group them by compartment, because sometimes they can it'll help you narrow something down if you just know the compartment. So we talked about this. Brady talked about this. So let's see if you guys can get this one. Yeah, hallux valgus. So I put this in the chat when Brady was talking about it, but the way I like to remember valgus and varus is I always associate valgus like with gummy, and so the joints are going to be kind of kissing each other. So that means that the distal part of that limb is going to be lateral, because if the joints are kissing each other, they can't be oriented immediately. They have to be laterally. So that's what usually helps me with that. Yeah, popliteal. Good job. Make sure that you know all of the lymph. And I say this every time I talk about lymph. They're not going to try to trick you. They're not going to give you some long pathway of lymph, because this is very clinically relevant, because you're talking about infection. If you're talking about metastases, you're going to see evidence of that in the closest lymph node. So the first lymph node that each section will drain to, because they can lymph node a biopsy and you can find evidence there. So clinically, this is very important because that's where you're going to find evidence of this. So make sure you know every single lymph drainage that is told to you in these slides. So Brady went over this, but we're going to hit it again. So hopefully this is super simple for you. Yeah, McBurney's point. So it's that 2/3 the difference from the umbilicus to the ACEs. That's a big thing. If they talk about appendicitis, that's huge. So make sure you do know these. McBurney's point is, I think, the most high yield one, but they can pull any of these. I remember, I think, them talking about the linea semilunaris with us for our exam, but spend a couple minutes on this. Don't only know McBurney's. They could ask McBurney's and they could ask another one. Collection of fluid, yeah. So again, the way they're going to test these embryological pathologies is they're going to probably give you a presentation and ask you how this pathology arose. So this, it's a collection of fluid in the tunica vaginalis. So being completely obliterated or not, you're going to get this fluid collection. So the difference between this and a hernia, you get this transillumination because, of course, the tissue in a hernia is not going to give you transillumination. So make sure you do know the difference if they give you something like this, because if you start seeing all of these things and you're trying to diagnose a hernia and then they give you like something transillumination. So make sure you can, by physical exam and by relationships to nearby structures, you can diagnose hydrocele versus hernia. And with hernia, you have the indirect, you have direct, inguinal, you have femoral. And so depending on what sheath they're going through, the laterality with respect to structures, make sure you know that. We have one vote for interspinous. Does someone disagree with her? Do we agree? Interspinous, yeah. So this is, like we said, this is the narrowest point in the pelvic outlet. And so this is going to be the one that determines safety of a vaginal delivery. So do make sure that you orient yourselves to these. I think the ones in grays are going to be the more high yield ones because they relate it clinically. But don't skip over those. It seems very low yield, but they will ask you a question or two. So. Yeah. So when they talk about the anterior drawer test, it's actually pretty easy because they'll say anterior versus posterior. The biggest thing is you need to know the orientation. So when they talk about the drawer test, they're talking about the tibia displacement. So make sure that you understand it's the tibia displacement with respect to the femur. So is the tibia going anterior or posteriorly? And then, like Brady said, he showed you that MRI image. You need to know how to distinguish between ACL on an MRI. Okay, we have a couple for Cyril.
Sorry, for the previous question, my screen went off. What was the answer? Was it ACL?
ACL, yes.
Okay, and that's because it's pulling anterior?
Yes, the tibia with respect to the femur, yeah.
Thank you.
Yeah, this one is going to be the sural nerve. So remember I told you to make sure that you pay attention to the boundaries of these sensory distribution. So the sural nerve here is going to do the posterolateral leg, and then on the foot, it's going to be this lateral little sliver right here. So make sure that you don't confuse that with the superficial fibular nerve that is anterolateral, but once you get the ankle, it's strictly dorsal. It's strictly the dorsum of the foot, So this is the anterior leg, but this is the dorsum of the foot. Don't let that confuse you, because this is dorsal, this is plantar on the bottom. But, and then Brady talked about the deep fibular nerve, so make sure, and then saphenous is going to be the medial side. Okay, Colles fracture, we're saying B. Agree, disagree? Awesome. You need to know the difference between a Colles and a Smith fracture based off of presentation, based off of physical exam, and based off of the images. The difference between the two, the mechanism is very similar. It's a fall on an outstretched hand, but it's going to present differently. So the Colles, the distal fragment, which is everything distal to the fracture line right here, this is going to be posterior, whereas Smith is going to be anterior. So now we're getting into more muscle phys. The rest of this is going to be more muscle phys. This particular question is from the muscle phys, one of the DLAs. Okay, so creatine, phosphorylcreatine. Any other guesses? Or do we agree, disagree? E, A, B, C, D, E. So the answer is going to be phosphorylcreatine. So if you haven't looked at this DLA, I pulled the information relevant to this question. So phosphorylcreatine is made at rest and it's stored. And if you have really powerful contractions, this can be used for energy production. Now, the reason it's not lactate, I would have assumed more people would go that way, is because lactate isn't stored at rest. It's produced during anaerobic metabolism, respiration, and this actually is not going to be able to supply the demands of the muscle. The demands are going to overrun the amount of lactate very quickly. And also, if you get too much lactate, you're going to have a decline in pH. You're going to become acidic. So makes sense. P, sure, I never said. Okay. But read through this. This DLA, I don't think is extremely high yield. I went through and just kind of highlighted a couple points because it's very wordy. This DLA is very wordy. So I just picked out 1 or 2 points that I thought were very important, and I focused on those. I didn't try to memorize this entire document, but I did pull out something that I thought would behoove you to at least take a look at. Okay, we have a couple for tight junctions. We have a couple for gap junctions. Gap, okay, more people are saying gap, and I would agree with you. So you need to know the difference between all the muscle types, but the reason gap junctions are so important in cardiomyocytes is because you don't want that entire organ contracting at the exact same time. So you're going to talk about a lot about this next week when you start CPR1, but you have a propagation of a signal in the AV node, and that is going to send its signal down the heart. So you'll learn that it goes from like point A to point B to point C to point D. And the reason it does this is because of the gap junctions. And what's actually happening is the calcium is traveling from cell to cell in those gap junctions. And you know, going over muscle physiology, that the presence of calcium is what causes muscle contractions. That's what happens. And so you'll hit this so hard in CPR, but that's the big thing, is those gap junctions are what are propagating throughout the whole organ. C, okay. Okay, we have a lot of agreement on C. So what are we talking about here? Step 1, what kind of muscle is this?
Smooth muscle.
Smooth muscle. And smooth muscle is very unique in that it has to sustain contraction for long periods of time. So what is the process that is indicative, or not indicative, but characteristic of smooth muscle?
They have like a slow rate of cross-stitch cycling, but also I did want to ask, they are stronger contractions, right? I'm not sure, because I remember I was in office hours with Dr. Toledo, and he was like, if my arm was made of smooth muscle, I could lift like 1 billion pounds, but I'll just be able to lift it very, very slowly.
Right. Austin, you are correct. It is the latch state. So let's talk about latch state for a second. Latch state, you are going to have decreased myosin ATPase activity and greater number of cross bridges. So you're not turning over as quickly. That's what this means. You have these cross bridges, they're engaged. A lot of them are engaged at a time, but you're not really cycling them. They're linked for a longer period of time, and this is to sustain that contraction. But since you don't have as much activity, you're going to have a lower Vmax, because the Vmax is the ATPase activity. So these 2 points go hand in hand with each other. And then because you're not cycling, you're not having as much ATP hydrolysis, because you're not getting that release, and you don't have to keep putting more ATP in the system to get it to continue to work. So it's continuous and passive contraction, which is called tone. And that's really important because, you know, smooth muscle is your vasculature, it is your digestive system, and those things, they need to be able to contract for long periods of time, very smooth, sustained contraction.
So would the answer be B or C?
C, lower rate of ATP hydrolysis.
Okay.
Yeah, you're not going to have a high rate of cross-bridge cycling because you want that to be low. Because if you have a higher rate, you're contracting more often and you're using a lot of energy to do so. Okay, so we have some for B, we have some 1 for C. Do you want to confirm either of those? Any other ideas? Another for B. Okay, so metoprolol is a beta blocker. So what it's going to do, it's actually going to prevent for this receptor to do its thing. So it's not going to really be an antagonist. It's actually directly blocking. Yes, Jeffrey, it's directly acting as a blocker, a beta receptor blocker, instead of just being an agonist or an antagonist. It's going to go and it's going to prevent this from even happening at all. So these are your examples, but this receptor, the beta receptor, is extremely important. But this all ties into inotropism. Wait. What? Oh man, it didn't do my question. Okay. So we're going to skip that because it didn't copy over my question, but I'll just ask the question. If you give a patient digoxin, which is a positive ionotropic drug, how is this going to affect the, okay, so somebody is already thinking, okay, yeah. So positive ionotrope, when you're looking at the tension length curve, it's going to be to the left. And so this is increasing contractility. So you'll get big on this, of course, in CPR. So this is a beta-1 agonist. You are increasing the ability for the heart to pump. So the example was a patient has systolic heart failure and is given digoxin. So in heart failure, the heart is not pumping as effectively. And so it's going to compensate, but it fails when it tries to compensate for too long. So what you're doing here, you're trying to increase the ability of the heart to pump. So it's called contractility. So it's force of contraction. You're trying to give the heart a little extra help. And that's what this ionotropic idea is. You're increasing its ability. And so that's why you would give digoxin to somebody who has systolic heart failure. Mm-hmm.
Could you say that digoxin and metoprolol are kind of opposite?
I don't know if I would call them opposites, because digoxin is an ionotropic drug, and what an ionotropic drug does is facilitate ion flux into a cell, whereas metoprolol blocks it. So I don't know if I would actually say they're opposite effects.
I think maybe clinically you get similar effects with blood flow, but the beta blocker is going to be concerned with heart rate, whereas digoxin is going to be concerned with contractility. So yes, digoxin will get more outflow of blood, and if you slow down the heart with the beta blocker, you're going to decrease blood flow. But y'all are going to get into that much more in CPR for sure.
The big thing here is just ionotropism.
Okay,
honestly. Yeah.
I did want to ask, so for the actual question itself, is it shifts the line to the left and shifts the line up?
I would say left, honestly. I would say more left. Yeah, because if I shifted it up, then this point would be up as well. Or that's how I would interpret this going up into the left. But I would just say left. They would probably give you this graphical representation and ask you at which point would you find a positive ionotrope.
Perfect.
Left, Stephanie. I would say left. So we have a few guesses for A. Does anybody disagree? Does anybody agree? D. Okay. So we have A and D. Not bad choices, not bad choices. But I would actually go with B. Transient calcium increases due to sarcoplasmic reticulum calcium ATPases. Here is why. Long absolute refractory period, this is more in cardiac myocytes than in muscle cells, and this helps make sure that the heart contracts when it's supposed to, that different areas contract when it's supposed to. At the level of the NMJ, that's not, we don't want to moderate at that level. Now, if you mess with this, with the NMJ, you can absolutely get tetanic contractions. And if I had given you an example of stepping on a rusty nail and now the person is going to tetanus, that would, I would be inclined to go more towards the NMJ. However, physiologic conditions, we prevent tetanic contraction. So tetany is this overall contraction of the whole muscle, is all of this stimulus going on and the muscle is contracting and it just doesn't let up. And so the way we prevent this is we put calcium back into the sarcoplasmic reticulum. So this increase is very transient. So remember, if there is presence of calcium, you're going to have that binding to troponin C, and then the sarcomere can do its thing, right? So calcium is present, you get contraction. So if that calcium is always there, you're always going to get contraction. But because we have these ATPases on the sarcoplasmic reticulum, you can get that back into storage. And so you don't have this sustained contraction. So this is how we're going to combat physiologic tetanus. But so that's that concept there. Now, if we are talking about pathologic tetanus because of a rusty nail or something like that, that's very high yield too, and you need to go over that. I don't have that in here right now.
Did you say rusty nail?
Yes. So you can get tetanus if you step on a rusty nail. And
do more with NMJ moderation?
Yes, I'm going to look that up real quick because I want to give you the exact wording from your slides. Come on. Where is it? Okay. Here we go. This is where I want to be. Maybe. Okay. I don't want to waste your time by trying to go through that. I'll try to find it in a minute. But if you, because you have to get, you have to get tetanus shots whenever you, every 10 years. And when you have to go to the emergency department because you stepped on something rusty, or if you have a, if you have a wound of some kind, they'll ask you when your last tetanus shot was. Oh, thanks, Brady. Okay, this one, E. Okay, any more agree, disagree? What are we talking about here? The difference between what?
Type 1 and type 2?
Mm-hmm. Yeah. Fast and slow fibers, exactly. Type 1 and type 2. Yeah, they have like 3 names. Yeah. So most people are saying A, B, C, D, E, and I would agree with that. So what kind of fibers are we talking about here?
You're talking about red fibers.
Yeah. Fast twitch. The way we know this is because this is we're talking about a muscle cramp. And so I didn't specify, but usually, we're talking about the leg or something like that. But that is going to be a fast type muscle. And you know this because this muscle is used for shorter distances and it fatigues fast. So these are the muscles that you are going to notice that you choose to use on a daily basis versus the slow type. These muscles are voluntary muscles, but you don't necessarily think about using them. So the answer is going to be a high Vmax. So for these muscles, it's more postural. These are muscles that you utilize, but you don't necessarily know you're utilizing them. And so these are the muscles that keep you upright, have posture and everything. And you don't want these to fatigue. And so that's why we have different kinds of muscles, whereas these, what muscles in the leg, the ones that are very active, the ones that are going to constantly be engaged and changing, these are very fatigable. And the reason they're very fatigable is because they are going to have a high capacity for anaerobic, whereas these are aerobic. These actually have low myoglobin and the high myosin ATPase activity. So this is going to be a high energy requirement here if you have high ATPase activity. So make sure that you do know this. They can put this graph on you, graph on the exam, unlabeled, point to one of these and ask a question about it. So this is one, it's in your notes, but I don't think they stress it in lecture, but it is high yield. Any guesses? So this doesn't have to do with the calculation or anything. It's a definition from your notes. We have one for B, one for C. One. Okay, the answer is going to be 1. So C. I'm going to show you why. So this is straight from your notes. It's just a definition. And I'm going to tell you why this is important and why it makes sense. So preload is like you're loading a spring, and preload and afterload, you're going to talk this to death in CPR. But for our purposes in MSK, you really just need to know preload is loading the spring. It's what you put on a resting muscle. Afterload is what you're working against to actually get a muscle contraction. So 1 gram is going to be the optimum length. Now think about this. When you're going through your daily lives and you are using your muscles, you're picking things up, most of the time for a, low weight thing, it's very easy to pick it up. But if you try to pick up a heavy box, you have to put a little more energy into it, right? You have to put a little more force into it. That's this concept right here. It's saying that at higher preloads, you're not going to have an optimum muscle length to get a good contraction. So 1 gram of preload, this is just a definition, guys. This is not a calculation. This is not something you're going to have to work through. It's strictly a definition. 1 gram of preload means the muscle is at its optimum length. And the reason why this is important is because to prevent injury, your muscle is not going to let you pick up something that's too heavy for you. And that's afterload. I have a question about afterload, and we're going to talk about that at that time. But this is just a definition. Just remember it.
So what would be a question around the 5 gram preload?
I don't know if they would throw 5 grams at you.
They're a little evil sometimes.
That's very true. It would have to be a situation. I have a question coming up about it, and I think we'll talk a lot more about the afterload at that point. And I'll relate it back to the 5 grams. Okay, some for D, 1 for C. INH stands for inhibition. That's my own little abbreviation for it. D. Okay, it is D. So myasthenia gravis messes with the receptors at the nicotinic receptor at the NMJ. So basically, it messes up these receptors. You don't need to know how at this point. You'll learn that in term 2. And you're not going to get as much action potential propagation because you don't have as many receptors here. So decrease receptors, decrease activation. So that's how you get the weakness of the skeletal muscle. So that's just a definition of how that happens. Okay, we have one for A. Hopefully this is easy for you guys. They like malignant hyperthermia. A. Okay, it is A. It's the ryanodine receptor. It's a mutation in that receptor, and normally it doesn't do anything, but the example they'll probably give you is an anesthetic agent. I think the example they gave you was succinylcholine. They call it sex. So this is going to cause abnormal release of calcium, and this causes heat buildup, and which gives you the hyperthermia. So they can ask you to, what's the receptor? They can ask you what you're going to give them. But yeah. Okay, last question. The sex and the halothane are going to cause malignant hyperthermia. The dantrolene is going to treat it. Okay, so we have a couple guesses for A. Yeah, this is A. So this is afterload. When we're talking about afterload in the muscle, we're talking about isometric versus isotonic contraction. And it basically is at what point are you actually going to get contraction of the muscle. So isometric contraction, you aren't going to get any muscle length change. And so this is not, the weight's not going to move. And so to protect your body against straining yourself, against hurting yourself, your muscle is not going to let you lift something that is past your capacity. So when we saw the graph earlier with respect to 5 kilograms, your ability to pick up that object drops very immediately. So that's what that is talking about, isometric versus isotonic contraction. But those are all my questions. I hope you guys enjoyed the session. If you guys have any specific things you want to go over, we can definitely hit on those.
Yeah, so we had a request to go over the hernias again real quick.
Cool. Do you have that pulled up, or do you want me to pull it up?
Yeah, let me. So I could go through it. I was just typing real quick. So the main thing for the hernias, so you want to the line of demarcation is going to be the inferior epigastric vessels. If it's medial to it, it's direct. If it's lateral to it, it's indirect. I think of indirect as having, since it's indirect, it has to take a longer pathway. So it's going to go through the deep ring and the superficial ring, whereas the direct hernia is just going to be superficial. Indirect is going to be congenital, and direct is usually going to be some sort of trauma from lifting weights, something too heavy. The other request was to talk about in sort of the limb development stuff. As Lindsey had mentioned, they're going to take a clinical aspect to it. So opposed to saying, how is normal development? They're going to say, you had syndactyly abnormal development, obviously. How did it happen? And their answer is going to be failure of apoptosis. Yeah. Okay. Yeah, the ice tie thing. Let me see. I could just pull that up real quick. Where is it? Yeah, I'll share it and show y'all the. Oh, here we go. Yeah, I'll share my screen real quick, Lindsey. Oh. Okay. If you see here, in regards to the descent of these spermatic cord layers, can you see my screen, Lindsey?
Yes, I can.
Okay, so these spermatic cord layers are going to descend into the scrotum. So it'll probably be first order, second order question. They'll be straightforward with it. So if you see ice, if you put like ties underneath ice, the I goes with T, the C goes with I, the E goes with E. So that's how I remember it. You'll keep in mind from the abdomen, the transversalis fascia is going to turn into the internal spermatic fascia, and so forth. If y'all have any other questions, yeah, let us know.
Good luck, guys.
Yeah.
Hi,
Let's see.
sorry.
Go for it.
Yeah, no, I just I don't know if you saw, but I'm just gonna ask about genetic stuff. If you have any tips about that, or like what to focus on for that, health specific.
Definitely know all the genes associated with anything they tell you about.
I remember a slide. It was from that long DLA, and it had to do with the trinucleotide repeats. It had yellow boxes on it, and it talked about what was it? Huntington's, Fragile X syndrome, and myotonic dystrophy. So you could, and it kind of tells you where along the DNA strand it happens, whether it's in the untranslated region. But that slide, if you can find it in that DLA, it's yellow. There's yellow boxes on it. It kind of tells you everything you need to know. Those are super important in regards to the genetics components to it. They'll ask you about whether it's autosomal dominant or recessive or whatnot, and kind of like what's the story behind that specific disease. Other than that, stuff like Duchenne's versus Becker's is important. Knowing that Duchenne's is more of a frame shift mutation versus Becker's is in frame. Therefore, Duchenne's is clinically worse. Also, like the differences between osteogenesis imperfecta 1 versus 2, one being a missense, one being a nonsense mutation. So just those little things will be good to know. Going into the exam for sure.
If they define an inheritance concept with respect to a disease, that's very high yield.
Is it important to go back and look at the histology slides presented in small group? So first, I would go. Yeah, I would. I mean, preferably, I would say go through the histo question book. Yeah. Then again, like if you have time, which nobody does, I guess you could always go through the small group stuff. The thing about small group is like they go a little bit too far into detail with some things, and you just kind of like, I don't know what's going on. That happens. So I think the histo book questions they choose, especially the images, correlate better for sure. If y'all have any to correlate, yeah. Say again.
You said the histology book is better than.
Yeah, histology questions. I think those correlate better to the high yield
group. Yeah, small group gives way too much detail. Too much detail. And a lot of small group, it's also, you get additional commentary from the facilitator that you were paired with that day. And so the facilitator may give you a lot of extra information that isn't necessarily super high yield for your purposes on a written exam. And so focus on what they give you in the lecture slides for histology.
And then another question. Shoot, I forgot my question.
No worries. Think about it. We have one here. With one day left, how should we focus on studying, grades, or just reviewing lectures? At this point, I personally feel, questions. The more questions you could do, the better. Even if you're doing them again, the more questions. It's a form of active learning. You learn from doing questions. That's the way to go. Maybe for some of the stuff like the muscle phys stuff and some of the histo, you want to look at the images. But I would primarily be focused on questions now for sure.
I was going to ask is Are they going to ask any lab concept questions on the exam, like any pictures of the cadavers or anything?
No, I think that's restricted. That'll be like on your lab exam at the end.
Okay.
When is that supposed to be? Y'all do that at the end of the term?
Sure.
Yeah, that's going to be a monster. I don't know that you need to worry about it right now, but yeah, it's certainly a different beast when the cadaver's not color coded for you, for sure. So you'll have to take some time to do that. But in regards to this test, no. As for the ultrasound stuff, no, you don't need to do that or focus on that too much. But when it comes time, I would definitely set aside time when it comes to it to going over the cadaver pictures for sure.
And then, do you guys have any advice on like how to start preparing for the final at this point?
The final? You don't have a comprehensive final.
It's not comprehensive?
No.
Well, I mean, technically it is. I mean, technically, so like you get the rollover, the 10%, right, Lindsey?
Yeah, but it's
Right.
not a completely comprehensive exam. Your last
No.
exam is going to be the CPR2. And so most of the content is going to be pulmonary, renal. And I mean, every exam has a certain percent of comprehensive questions, but it's not going to be a final exam for term 1. It's just your last exam.
I don't know why I thought we had a whole...
No, it's going to be the same. Yeah, we do.
All of term 1, but you guys don't have that first year.
Yeah.
But yeah.
You can worry about that next term. Yeah.
Completion exams are after the term. If you are not able to sit for an exam for any reason, then you can be granted the ability to take a completion exam. Try not to do that though, because it'll have been far away from the time when you were actively studying that information. So if you can avoid it, I would avoid it.
What is BPM OCEX?
The OSEX, that is your clinical skills exam.
Oh, okay. How are we going to do that with?
So you are going to get more instruction about that in small group. It is going to be over Zoom. You're going to have a patient encounter with an actor patient. We don't really know how that's going to go for term 1 and term 2 yet. But we're supposed to have a little practice OSEX in small group when we get closer to that.
All right. Thanks, guys.
Yeah, no worries.
Good luck.
Thank you.
Have a nice evening.
Any last minute questions?
No, thank you so much, Brady. Bye.
Yeah,